All right, an official good afternoon to everyone who's on our call today. And for some of the folks who have joined us, I recognize that it might be evening where you are or morning. So good evening or good morning, whatever is most appropriate for you. On behalf of the Council on Tall Buildings and Urban Habitat and its local Chicago chapter, I'd like to thank you all for joining us for our April virtual program. As a preface to this, it is our first virtual program, so if there are any little hiccups along the way, I apologize in advance for that, but I thank you for your patience as we deal with them. For those of you who might not recognize my voice, I am Shelly Finnegan, CTBUH Chicago Chapter Chair and Global Technical Sales Engineer at ArcelorMittal, the world's leading steel and mining company. A lot of effort has gone into the development of today's program, and in fact, the esteemed group of panelists that we've brought together have all committed to advanced slide deck submissions, which is a feat in itself, and not just one, but multiple dress rehearsals for this event. So I'd like to extend a big thank you to them for this commitment, and to the CTBUH Chicago volunteers who have made this event possible, especially Kate Peevler, who's our secretary and acting programs chair, Heather Spray, who is a CTBUH Chicago Advisory Committee member and the Global Initiatives Coordinator at CTBUH. They have both committed endless hours, including late into yesterday night, coordinating this program, prepping our speakers, and learning how to use CTBUH's new Zoom platform alongside me. So in addition to them, I'd also like to thank our chapter communications team and every member of our local organization who's been enthusiastically spreading the word about this event. Thank you to everyone. We have hundreds of registrants for this event, and we're very excited to put it forward today. Because this is the first virtual event, I'm going to apologize yet again to the attendees who are just joining us. If we do have some hiccups along the way, it's not because of a lack of preparations, but it is, as we all know, just us being submitted to the technologies that we have to deal with today. However, in a continued attempt to mitigate the number of hiccups that we experienced today, we have developed some best practices, of which I'm going to just walk through with you guys here. First, an overview on our program. This program is being recorded and all attendees are entering into the meeting on mute. And for all of our attendees who are here, your microphones will remain muted throughout the event. In addition, today's event is going to qualify you for 1.5 continuing education credits. They'll be earned by attendees who view the complete program and register for those credits after the event. Our webinar features 7 total panelists with their presentations broken down into 3 introductory talks and 2 detailed case studies. The question and answer session will be moderated at the end of all of our presentations. And though the panelists will not answer them in real time, you as an attendee can submit them in real time by using the Q&A button that shows up at the bottom of your Zoom platform. We have a little image of it represented here for you. Unfortunately, we'll only have time to answer select questions at the end of today's call, but the webinar organizers will be collecting all of the questions and they'll be considered for written response after the program is complete. It's important to note for all of our attendees that the panelists that we have here today are representatives of the AEC industry, and they are not specific to any of the healthcare organizations that we might talk about today. Therefore, these folks are not equipped to, nor at the liberty to talk about any information directly related to patient loads, recovery rates, and what might be obvious, but I just want to state it here, they cannot provide any diagnoses or advice related to COVID-19. At the end of our Q&A session, when our webinar closes out, attendees will be invited to a brief survey, and this is where you will register your continuing education credits, and where you will be able to sign up for CTBUH Chicago and CTBUH email distribution lists. We hope that you'll share your details with us to continue participating in our mission to disseminate knowledge and best practices to stakeholders of the built environment throughout the world. Lastly, after our program is fully complete and everyone on this call is settling back into their form of a normal routine right now. The webinar organizers will send closeout information, including a link to the recording, to the email address with which you registered for this event. Now, with those housekeeping items in order, I have just a few remarks that I'd like to go through before we get to our panelists. I recognize that today's virtual program features the most diverse and highest count of registrants that the CTBUH Chicago chapter has ever entertained. We're incredibly grateful for this interest, and we recognize that it is the direct result of the esteemed group of panelists that will speak with you today. In response to the diversity in our attendance, I do want to just walk through what CTBUH is and how the CTBUH Chicago chapter fits into the story of CTBUH as a whole. For those who are unaware, the Council on Tall Buildings and Urban Habitat has been in existence for more than 50 years. It was founded at Lehigh University in 1969, with the mission of the organization being leadership of the conversation on best practices for tall buildings and sustainable cities. As of 2020, the CTBUH network includes more than 2 million individuals who work at 10,000 offices around the world. The cross-section of participants is represented here by both profession and region. And again, I recognize that for today's program, we have attendees representing even a wider range of professions than what we have represented in our normal membership. And we have also folks who are joining us from all corners of the world. So again, I thank you for doing that. Now in 2003, the council moved from Pennsylvania to Chicago, and it is still squarely headquartered in our fair city of Chicago. I apologize. Ooh. That's my bad. Advancing a little quick through the slides there. So even though the CTBUH organization is headquartered here in Chicago, it's represented throughout the world by offices in Shanghai and Venice, and then 13 chapters around the world, and numerous individuals who are representing the mission or serving to spread the mission of CTBUH around the globe. Now, today's program is being hosted by CTBUH Chicago, which is the local chapter of the council. We opened our doors in December 2018, and we have since led a flurry of initiatives at the local scale. With just about 20 extremely active volunteers, we've been serving more than 50 membership organizations here in Chicagoland, which equates to an excess of 3,000 individuals. Our prior activities include 7 unique educational programs, much like today's, but previously we were hosting these in person. We had 3 tours of major construction sites in our city, 1 global walking tour, and CTBUH's first ever tall building pub quiz night. We have also established a fully functioning Future Leaders Committee, which is there to serve our emerging professionals, and our chapter participants have enabled the release of a white paper series on the modernization of the Chicago Building Code, which was just released earlier this year. It's incredibly important that I take a moment to just recognize that our local chapter and the programs like today's that we host are driven by our volunteers. Our chapter leadership is comprised of our executive and advisory committees, our operational and technical subcommittee chairs, and a collection of enthusiastic participants who comprise our operations and technical subcommittees. Our commitment to bringing high caliber programming and knowledge dissemination opportunities to AEC stakeholders is strong, and we trust that everyone who is attending today will recognize the fruits of our labor. Therefore, we ask that when you leave on a high note from today's program, please consider, if you're not already, becoming a member of CTBUH and helping us lead the tall and urban conversation. For your reference, you can contact our chapter directly at chicago@ctbuh.org, or you can visit ctbuh.org/getinvolved to learn more about the organization. Now, without further ado, and thank you all for giving me a few moments of your time to talk about our organization, we are going to move into our webinar. The CTBUH Chicago April virtual program is titled Agile AEC, Planned and Unplanned Responses to Pandemic Crisis in Chicago. This program has been designed to showcase how ingenuity from our AEC firms has led to real-time innovation to help fight COVID-19 and has enabled healthcare facilities to be prepared for or respond to this pandemic. Today's first panelist is Joseph Burns, Managing Principal at Thornton Tomasetti. We'll just go ahead and get Joe's microphone pinned on and let him take it from here. Can you hear us, Joe?
I can hear you, Shelley. Can you hear me?
We sure can. Go ahead.
Well, thanks. So we are now in our 6th week of working from home. And in addition to carrying on with our projects, Thornton Tomasetti has been able to support some COVID-19 initiatives remotely. Next slide, or first slide, please. So first up, we are modeling lungs remotely. Our life sciences specialists in computational fluid dynamics have teamed up with ventilator manufacturers and academics to validate a range of concepts to improve patient outcomes. Our project Breathe Easy focuses on the creation of patient-specific digital twin replicas of the lungs of COVID-19 patients based on medical imaging and simulations of lung airflow and blood flow, running on our on-scale cloud simulation platform. The data can be used by healthcare professionals to determine such things as the amount of time a patient spends on a ventilator and adjusting ventilator settings to improve their performance. For hospitals, one of the first lines of defense facing COVID-19 is to contain affected patients in negative pressure airborne infection isolation room, or AIRS. More hospitals need to build more AIRS. And we are collaborating with a manufacturer of fan-powered HEPA modules and a distributor to help healthcare facilities get AIRS up and running quickly. Our team is set up to work remotely to coordinate design efforts, equipment delivery, assist in installation issues, and review post-installation certification to ensure that these rooms operate properly. Next slide, please. For alternate healthcare facilities, Thornton Tomasetti are involved in several efforts to alleviate the strain on our hospitals. Our forensic and civil engineering teams are providing reviews of existing and temporary structures as well as design services where needed. And finally, we are developing an app to help protect employees. The COVID-19 crisis is expected to subside unevenly by geography and pace. At some point, restrictions will be lifted and we will all start to return to our offices safely and productively. With this in mind, our core R&D team, collaborating with our HR team to ensure compliance with privacy requirements, is developing Encounter, an open design, web-based contacts tracking app to allow our employees to quickly and safely re-enter our shared work environment. Once we beta test this inside our firm, we plan to share it with others. And that completes my quick review of Thornton Tomasetti's collaboration with others in responding to this pandemic.
Thank you, Joe. I must say it's really impressive to see Thornton Tomasetti connecting right into the healthcare response. I'm especially impressed by how you're equipping workers with that digital twin of patients' lungs, and I'm looking forward to seeing more images of that promoted on your guys' social media feed and in the news, I hope. Next, we have Devin Lavigne, who is the principal and co-founder of Houseal Lavigne Associates here in Chicago. We're just going to get Devin's mic up and running, and then Devin, when you're online, can you just let us know?
Yeah, I think I'm all set.
Perfect.
Great. So my name is Devin Lavigne. I'm a principal and co-founder of Houseal Lavigne Associates. We're based in Chicago. We have a national practice. We specialize in urban planning, urban design, economic development, and more recently, GIS, Geographic Information Systems. And we do have, I guess, a national practice with a reputation of just analyzing and presenting information in a compelling fashion, including our work with maps, cartography, and 3D. In the next slide, just an example of how we sort of don't always put everything to work. This was a map we did last year for a big GIS conference where we took the National Land Cover data set and turned it into an interpretation of the Settlers of Catan board game. And the next slide, more recently and relevant to this webinar, this spring during a team huddle, we started looking at the Johns Hopkins University COVID dashboard. The dashboard's been widely publicized as a way to track sort of the pandemic. I just checked to date, there's been 1.3 billion views of this dashboard. And it's a 2D map, and to us, the limitation here was particularly prevalent on the East Coast, where we know there's been a high incidence rate in New York, but the size of the polygons, it's called a graduated symbol, really starts to hide the other data. And so we built, and if you see the next slide, we tied into this live data feed, and we built what we call the COVID 3D Explorer. So instead of seeing these incidence rates as a sort of large red circle, we brought them up vertically. And so it allowed us to start to see the impact of the pandemic a little better. So here on the East Coast, or New York, you can see really there's 6 or 7 counties that are affected, tapering off as you move west. So Suffolk County on Long Island versus New York City. And so we're extruding all of these points vertically. And it's just, I think, a neat tool and a way for us to kind of explore the data. Esri, the leader in GIS, loved it. They feature it now on an application site where they've put a collection of apps that are helping municipalities and cities across the world analyze and respond to the COVID pandemic. And they've asked us to feature this 3D Explorer. So we're continuing our work on it, adding more features, the ability to compare multiple counties and look at temporal data, really the spread over time. And the next slide is just a link if you want to sort of see for yourself. And I think it'll be in the follow-up email, but yeah, thanks again for the opportunity. And I think that's it.
Fantastic. Well, thank you for that, Devin. Our final panelist, who will highlight real-time innovation that's helping to fight against COVID-19, is Mariusz Klemens, architect and urban designer at Krueck Sexton. Mariusz, may I pass the mic to you quickly?
Yes, thank you. Hi, everyone. Before we jump to the next slide, I just wanted to briefly introduce our topic. Our story involves a direct response to the increased demand and shortage of the face shields for the healthcare workers. Our team began working with the Resurrection Hospital in Chicago, whose feedback influenced the design of our face shield. As the available open source designs have not met their protection expectations, we have curated a unique solution to address and provide maximum protection based on the physician's guidance. Based on their specific needs, our design is an original design. Their version of the best shield, which they were actually wearing, was industrial welder shield. So you can imagine how uncomfortable and how heavy that might have been. So we have put together a short video to document part of our process that we would like to share with you right now. The idea began with a phone call to check in with my sister, a doctor at Health Resurrection Medical Center in Chicago. She and her colleagues were working under stressful conditions, and when she told us of shortage of supplies, medications, and personal protection equipment, I thought, we can make face shields for you. We began sharing images of open source shields others have produced to get feedback. Through consultation with her and other physicians at the hospital, we received a list of must-haves. Head coverage, extended protection below the chin line, coverage of the ear, no penetrations in the front plastic, no hard to clean and disinfect fabrics, rubber, or any other materials. Internally, we've got the go-ahead to order printer and materials. The studio met online to discuss product design. Sketches were shared to determine the best design of the shield, and special attention was given to the band. We had our first prototype in a day. In 3 days, we had a usable prototype for the hospital for testing. Additional feedback altered the design some more, greater head coverage and coverage of the ear. We found a partner in Peterson's. We delivered the first 20 3D printed and assembled face shields. We continue our production to support ICU and ER at the Resurrection, with a goal to find other hospitals in the area to assist. Our prototype was submitted as a prototype in progress or under review on the US Department of Health response to C-19. Since we recorded the video, we have supplied close to 80 fully assembled shields, and we keep production going to satisfy the demand. We have also expanded production to 1 additional printer. Our open source prototype is also available for everyone's download on the US Department of Health or by directly contacting us. The prototype is also under review for testing at US Department of Health and FDA. Thank you, and I'm very happy to represent Krueck Sexton studio that continues to look and investigate ways to repair the world within and beyond architectural practice. Thank you.
Thank you, Mariusz. That is a really thoughtful and responsive initiative, and we appreciate you and Krueck Sexton taking the time to share it with us, just as much, I'm sure, as the healthcare workers who are benefiting from those masks appreciate what you guys have done. So I'm going to take a quick moment here to pause. We have had a couple of hand raises come up, and I know that we have not enabled a chat function in our system here, but if somebody is facing a dire technology issue that is related to the Zoom platform, if you would like to submit any questions into the Q&A, then the the webinar organizers will be able to see your feedback in there, and then we'll try to address your issues. But now I'd just like to thank again our first 3 panelists for discussing the transferable skills that their firms are using in response to the COVID-19 pandemic. With so many talented professionals in the AEC industry, it's no surprise that we've found new ways to support the global fight against this pandemic. Moving on to our detailed case studies, I'm very pleased to be introducing our first team, Jerry Johnson, who is principal at Perkins+Will, and Craig Kos, healthcare studio leader at ESD. Jerry and Craig will tell you a really incredible story about how Rush University Medical Center used foresight to uniquely prepare for the crisis that we are experiencing today. And from my own experience as a COVID-19 patient, I can personally attest to the effect that this has had on the type of care that this healthcare organization is able to provide. The sense of calm in the face of this storm permeates throughout the entire staff, and I will be forever grateful for the support that they gave me as I sought to understand my diagnosis and to move forward from it. So thank you to everyone who was involved in this project and for being so ready for this unprecedented crisis. So now we're going to pass the microphone over to Jerry and Craig. Are you guys ready to enlighten us about Rush University Medical Center?
Yes. Shelley, can you hear me?
We sure can. And Craig, are you on the line there?
I'm on.
Perfect. All right, you guys take it from here.
Okay, well, thank you, Shelley. Hello, it's great to be with you all, at least virtually, for this program. My name is Jerry Johnson. I am with Perkins+Will Architects. I'm a design principal who worked on the Rush transformation projects. It's a privilege to speak to you today about the planning and preparedness at Rush for a crisis such as the current pandemic. This planning was an important part of the Rush transformation. The medical center's leadership, foresight, and vision for their transformation has enabled Rush to respond to the current crisis in an effective and very efficient manner. This transformation is a great example of the value of proper planning for a crisis. Next slide. Almost 20 years ago, Rush began planning for a major transformation of its facilities and operations. The transformation had many goals, including improving patient safety and being prepared for a regional healthcare crisis. At the heart of the transformation was the construction of 5 new facilities listed here. These projects totaled over $1 billion in cost and included over 1 million square feet of new space. From 2006 to 2012, these projects were programmed, designed, bid, built, and occupied in less than 6 years. The projects were built sequentially in order to maintain operations of the existing facilities. To accomplish the transformation effectively, Rush created an Office of Transformation. It was led by a full-time Rush senior hospital administrator and included nurses and doctors dedicated to the projects. This group collaborated daily with architects, engineers, and contractors throughout the design and construction phases. This team was also tasked with implementing operational changes, such as improving supply chain management, building maintenance, and improved technology. This collaborative approach was key to the successful incorporation of operational initiatives and protocols with the planning of new facilities. All the transformations have proven highly valuable today as the hospital deals with the current crisis. One of the doctors on the transformation team was Dr. Dino Romero, Chair of Emergency Medicine at Rush. His vision, as well as that of others, was instrumental in thinking about a much broader purpose and design for a new emergency department. Next slide. Last week, I found this quote from Dr. Romero from the time the tower opened in 2012. It struck me how far-sighted the transformation vision was for the projects. The tower was designed in the wake of the 9/11 attacks and the anthrax attacks that occurred shortly thereafter. While Chicago had many trauma level 1 facilities, it was felt that the city needed a place that could respond effectively to a large-scale attack or deadly pandemic. The old emergency department would need to be replaced with a new facility that redefined the definition of mass casualties and be able to respond to a wide variety of disasters. The potential disaster scenarios discussed included terrorism, industrial accidents, and a pandemic. This amount of responsiveness requires a high level of infrastructure flexibility, and flexibility can be expensive. For the new emergency department, Rush was able to afford enhanced flexibility through private donations and grants at both the federal and local level. The largest grant came from the Robert R. McCormick Foundation, which is a Chicago nonprofit that supports local civic organizations. The emergency department was named in honor of the foundation. Next slide. The Rush Tower opened for use almost exactly 8 years ago. The 304 beds represent about 45% of all the beds at Rush. The top 5 floors, known as the Butterfly, are dedicated to acute and critical care beds. Level 9 is the main mechanical room serving floors above and below. Level 8 is for women and infant services, and levels 4 through 7 are for procedures and surgery. Level 3 is for imaging, and the entire first floor is dedicated to the emergency department in the main entry lobby. Next slide. The new emergency department is 40,000 square feet. It consists of 60 treatment rooms divided into 3 20-bed pods. In a typical year, Rush has 70,000 emergency visits, or an average of 8 patients per hour every single day. The emergency department has a 5,000 square foot enclosed and conditioned ambulance bay, which was designed to serve multiple uses in the event of a crisis. The ambulance bay can be seen in the photo on the right. It sits proud of the north facade on the ground level facing the Eisenhower Expressway. Drop-off for walk-in patients is just to the right of the ambulance bay. Surge capability has been built into the emergency department as well as into the surrounding lobby space. Next slide. This is the first floor plan on a typical day. North is up on this plan. Most of the time, the ED acts like a large state-of-the-art emergency department. The main entrance to the building is on the south. The emergency walk-in entrance is on the north. The ambulance bay is on the north with easy access from the expressway. To deal with an industrial accident involving hazardous chemicals, beneath the ambulance bay is a 10,000-gallon holding tank to collect runoff from the washdown of patients who have come in contact with such materials. The holding tank prevents contaminants from entering the city's wastewater system. Decontamination rooms are located between the ambulance bay and the emergency department. Each of the 3 20-bed pods has one isolation room with negative pressure. Negative pressure prevents air within the room from flowing out and into the corridor. All air within the room is exhausted out of the building and not recirculated. To provide even greater flexibility, entire pods, even all the pods, can be converted to negative pressure to prevent the spread of an airborne contagion. To the southeast of the pods are imaging rooms and the emergency department support spaces. Next slide. This is a photo of the interior of the emergency department. A couple of key features that I would like to note. The treatment rooms all have sliding or folding glass doors, not fabric curtains. This helps with infection control, acoustics, and permits family privacy while still allowing a high degree of visibility. These doors also assist in containing airflow if these rooms are converted to negative pressure. Another feature built into the design is that these rooms are larger than you would see in a typical emergency department. This allows more people to work in the rooms, and in the event of a very large surge, 2 patients can be treated in one room. Note in the distance the red circles, showing a room built with 2 head wall ports for medical gases, data, and power. To my knowledge to date, with the current crisis, the ED has not had to put 2 patients in one room. Next slide. Rush has received a lot of national and local attention for its high-level preparedness for this pandemic. On April 9th, this headline appeared above an article in the Chicago Tribune. Current patient flow statistics in this presentation come from this article, and they may have changed since its publication. A key word here, and something that Shelley said, is calm. Everyone that I've talked to is so impressed with how calm and orderly the hospital is functioning, despite being incredibly busy. I think calmness comes from having all the important pieces ready and in place and having them function according to a prepared plan. There is confidence and calmness that comes with adequate preparation. This includes access to adequate amounts of equipment and the preparedness training of the teams. This is a credit to the far-sighted planning and ongoing preparation that occurs at Rush. Next slide. This is a floor plan of the ED as it is functioning today. Because of its robust infrastructure and safety protocols, in 2014, Rush was designated the destination hospital in the region for Ebola patients. But that crisis did not grow to the extent that the medical center had to implement surge mode. On March 4th of this year, Rush saw its first COVID-19 patient. It had actually been preparing for this for weeks. The medical center was ready when the patient arrived. 11 days later, anticipating the possibility of an increasing influx of patients, the Rush Tower, for the first time in its history, implemented surge mode. It should be noted that all hospitals have disaster preparedness plans, but Rush is unique in the breadth and scope of its plan. Surge mode is defined as preparing for the possibility that maximum capacity may be exceeded, and Rush was prepared. Today, the ambulance bay functions as an advanced triage area for patients coming to the medical center with COVID-19 symptoms. Within the bay, patients wait in chairs spaced 6 feet apart. You can see in the photo in the upper left-hand corner. They are evaluated in privacy within pop-up tents. And if their symptoms are mild, they are told to go home and isolate for 14 days. If their symptoms are serious, they are brought into the ED into one of the pods that has been dedicated solely for COVID patients. This entire pod can be converted to negative pressure. If needed, other pods can also be converted. As surge mode was implemented, the main lobby was then equipped for treating non-COVID patients should the ED become full. The lobby can now be used to serve patients with low-grade emergencies. The intent of the surge mode plan is to provide enough space and a throughput of patients to avoid commingling of people with and without the virus. Next slide. The photo on the left is the main lobby on a typical day. The red circle indicates a door that provides direct access to the ED. The photo on the right shows how preparations were being made during surge mode to set up treatment cubicles for patients who need treatment not related to the virus, should the ED fill to capacity. Next slide. A very unique feature of the lobby is that all the columns have a small concealed door that unlocks to reveal a panel that provides access to medical gases, data, and power. This avoids having to bring tanks and power lines into the space to serve patients. It makes setup for the crisis much, much faster. Next slide. These photos show further preparation of the lobby with equipment and furniture to receive patients should the ED exceed capacity. As part of the RUSH transformation, RUSH completely rethought and expanded its supply chain process and storage capabilities. Supplies can move quickly and efficiently from a facility beneath the orthopedics building via a tunnel under Harrison Street using automated guided vehicles. Next slide. This is a typical acute care floor plan. Typically, a small percentage of ED patients are admitted for critical care. Today, that admission rate is 30%. RUSH has a robust intensive care capability, and if the need arises, the Butterfly has a wing of acuity adaptive rooms that can be converted from regular to high acuity negative pressure rooms in about 2 hours. On a typical day, the hospital has 40 isolation rooms, but the isolation room capacity can be increased by 32, bringing total capacity to 72 beds for serious COVID-19 cases. According to the Chicago Tribune article, it is estimated that 1 out of every 20 people requiring hospitalization for COVID-19 in the state are being treated at RUSH. It is also estimated that somewhere between 20 and 25% of all ventilated COVID-19 patients in the state are currently being treated at RUSH. RUSH is used to having a very full ICU, but the difference now is the high degree of sickness and the duration of the patient's stays. Latest reports are that the hospital is maintaining well. RUSH patient flows are watched closely throughout the state to see how the city and the state is coping with the surge of patients. With respect to facilities during a pandemic like this, the most important component in creating a safe environment with a highly contagious respiratory disease is the mechanical system. A typical floor has isolation rooms within each unit, shown on this plan in red. RUSH has designated 1 whole unit just for COVID patients. The flexibilities and capabilities of the mechanical system is a critical component to dealing with the pandemic. So with me here today, virtually, to explain the design of the mechanical system is our engineer from ESD, Craig Kos. Slide.
Thanks, Jerry. Before we take a look at the mechanical systems, I'd like to take a minute to review RUSH's project goal of being able to respond to a CBR event, as you noted earlier. A CBR event is a mass casualty event involving chemical, biological, or radiological agents. When a CBR event occurs, it challenges the hospital's ability to treat patients under their normal operating conditions. So again, as you mentioned, Jerry, for the new RUSH hospital, the design team was challenged to increase the capacity to be able to address one of these events and create a surge mode to service patients that have been exposed to a chemical or biological or radiological event. As you can imagine, from an HVAC standpoint, patients that were exposed to a biological or radiological event, the most important thing is being able to isolate those patients from the rest of the patient population. the current biological event we're in is obviously the coronavirus. It causes COVID-19, which we know is mainly transmitted through droplets generated when a person coughs or sneezes. Now, when the virus is attached to a droplet, it's heavier than it is on its own, and it quickly falls to a surface, floor, door handle, where it's transmitted to other uninfected people when they touch those surfaces and then touch their face, which is why we hear so much about washing your hands consistently. We aren't totally sure that the virus can transmit from patient to patient or from person to person through the air. We're not 100% sure that it's airborne, that it's viable as an airborne transmitted disease. But the rest of the coronavirus family has those types of transmission modes. So ASHRAE at this point has issued a statement saying that the transmission of the virus through the air is sufficiently likely that airborne exposure to the virus should be controlled. So in the hospital, we control the movement of particles and viruses with pressurization. Slide, please. Pressurization in a hospital can refer to negative, neutral, or positive pressure. And really what that refers to is the pressure in the space relative to the surrounding spaces. In a negative pressure environment, the spaces around the room have more pressure than the space within it. We're able to achieve negative pressure in our space by removing more air from it than the HVAC system supplies. Next slide, please. So negative pressure is important because airflow tends to move from areas of higher pressure to lower pressure, and it moves the particles along with it. Typically, as Jerry mentioned, the hospital has about 40 isolation rooms that are standard and set up for this operation, or for treating patients with infectious disease. The isolation rooms are negative to the surrounding spaces, and therefore airflow moves from the surrounding spaces into those spaces, keeping the virus particles contained to the space. The diagram on the left shows a typical isolation arrangement where we supply air above the caregiver. That air moves across the patient bed into a low wall exhaust outlet. The key to achieving these pressurization control is the supply VAV box, or supply control box. It's on the bottom of the diagram, and the exhaust box is shown on the top of the diagram. Those boxes can be set to control the amount of air being pushed into the room and removed from the room. Next slide, please. So as we looked at in the other plan, there are a couple of isolation rooms per floor, but in a surge mode, we need to be able to accommodate more patients, we need to isolate a higher level of patients. So when we look at the floor plan, the patient tower is separated from a mechanical standpoint into 4 quadrants. Each of the risers serving those quadrants is highlighted in the diagram that we're looking at now. The 4 blue outlined shafts are dedicated to each of the quadrants they're located in. And if we look at the right-hand corner, the red riser serves the red patient rooms along the perimeter. So let's zoom in on the area there that's in dashed in the next slide. As you can see, each of these rooms has the dedicated supply box highlighted in green and a shared exhaust box highlighted in blue. So during normal operation, the supply or green box provides a little bit more air than we're removing from the room for a slightly positive room to keep the room clean. But when we switch to a surge mode, we are able through the building controls to draw more air from those spaces than we supply by increasing the airflow through the exhaust box in blue. That starts to draw air in from the corridors. It makes the patient rooms negative to the spaces that surround it. On the next slide, we'll look at the ED. You can see the emergency department is arranged in a similar fashion with supply boxes in green and exhaust control boxes in blue. Each of the patient rooms is able to be transformed into a negative pressure environment. On the next slide, we'll look at how this is achieved from a system perspective. The hospital at Rush is supplied air throughout the building by 12 central air handling units that are headed together on the 9th floor. Combining all of the air handling units into one massive distribution system allows the ability to take a whole riser and switch it over to exhaust as opposed to return to the building. If we look up at the upper right-hand corner where the star and the brackets are, if you imagine the northeast corner of the plan in red that we were looking at on the previous slide, we can see that we can take one whole riser and convert that to exhaust as opposed to return. This is achieved by having a dedicated return system on each of the return risers. When the air and that system is returned back to the building, or excuse me, is drawn down the riser, the return air system has the ability to direct all the air to the outdoors or return some of it back to the building. So when we're in surge mode, we can do the same thing with the ED and one of these risers within the building to create the negative pressure environment and to exhaust all that air to the outdoors without recirculating it back to the building. On the next slide, I'm going to turn it back over to Jerry to wrap up our segment. Thanks, Jerry.
Okay, can you hear me?
We sure can.
Okay, well, thank you, Craig. I just wanted to close by saying thank you to all the employees at Rush and all the essential workers who are so dedicated and skilled at helping Chicago and the nation through this pandemic. Rush is helping smaller hospitals by accepting patient transfers and offering assistance. As an academic medical center, they are constantly innovating, leading, and sharing new approaches to the treatment with the medical community. Rush experts often talk to the national and local media, offering frontline insights and recommendations. The story of the Rush transformation is a great example of the need for wise and far-sighted planning and leadership that allows an effective response when the need occurs. Thank you again.
And thank you to Jerry and Craig for presenting this really impressive project. And again, I echo Jerry's sentiment of thanking everyone at Rush and all of the essential workers who are helping everyone through this pandemic. So even with the best laid plans, we've found that this pandemic shows that that can never be enough. In contrast to the advanced preparations at Rush University Medical Center, we're all quite aware that our healthcare industry had to make significant adjustments to respond to the crisis of COVID-19. Our next panelists, Tom Kaplis, Vice President at Walsh, and Doug King, Principal at Stantec, will walk you through the Herculean efforts that were required to convert our McCormick Place Convention Center to an alternate care facility to support our healthcare systems in this pandemic. Tom and Doug, are you guys connected to your mics?
Can you hear us?
I certainly can. Yes. So I am going to turn the floor over to you and thank you for being with us today.
Thank you for having us. So again, Tom Kaplis, I represent the Walsh Group, which is a fourth-generation family-owned company providing design, build, finance, operation, and activation services across 19 offices across the country. My role and responsibility is Vice President and Business Group Leader of our National Healthcare Program. I'm joined here by Doug King, who was our consultant on the McCormick Place Convention Center Alternative Care Facility.
Thank you, Tom. Yeah, I'm a principal with Stantec, which is a global AE firm. I work in the healthcare practice group here in Chicago, actually worldwide, with a focus mostly on academic medical centers, large scale, and VA facilities. I've had the pleasure of collaborating with Tom and his group at Walsh over many years on several large healthcare projects.
So if we could go to the next slide, we're going to talk a little bit about the scope of work and frame the opportunity here. So the first thing is that the city of Chicago and its surrounding areas really does have a very robust healthcare community. And the purpose of the project here, or the opportunity, was to really provide a pressure release valve for those hospitals. Now, we're not going to go into the exact wording of how this was put together because there's many layers of folks that were involved in this, from FEMA to the U.S. Army Corps of Engineers, IEMA, but really the bridging document for this opportunity came from what is called a performance work statement from the U.S. Army Corps of Engineers out of Huntsville. And this was done for multiple alternative care sites across the country. The Corps spent quite some time putting together PWSs for fairgrounds, hotels, and convention centers like the one that we're going to talk about here today. So slide. We wanted to frame the opportunity and give you an overview of the McCormick Place. The McCormick Place Convention Center in Chicago is the largest in the country. And for those of you that have been here for an auto show or a convention, know that it has millions of square feet. What we're looking at today here is Halls A, Halls B, and Hall C in the center building in the graphic. Slide. We also wanted to give you a sense of the scale of time here. This all happened very, very fast. 3,000 capable beds within 25 days. From a proposal which was given to us on a Saturday evening to a phone call on a Sunday morning awarding us the project, and construction beginning the next day, hundreds of beds were delivered in a very short time frame. In fact, the first 500 beds were delivered in this alternative care facility within 5 days. 7 days after that, another 1,750. And then within 25 days, we had the entire project completed. So as you said, a very Herculean effort by a lot of people. Next slide. Next slide again. So the team. There are a lot of people involved in this opportunity. First and foremost, our customer here is the Metropolitan Pier and Exposition Authority. They were tapped on the shoulder by the state, by FEMA, by the U.S. Army Corps of Engineers to be the administrators of this project. So we had many layers of teams here. We had Walsh Construction, who hired Stantec as our consultant. We also had the city of Chicago, who had what we are called wraparound services, which is really the activation of the space and operations and logistics. Slide. So as I said, very quickly, we sprang into action. We submitted a proposal on a Saturday evening, on a Sunday morning, and by Sunday afternoon, we had over 50 people at the McCormick Place site ready for action. Slide. So I'm going to let Doug now take over a little bit more about the process.
Right. I'm having a little lag time on slides, but I think I can do it. Hours after award, when Tom and his group gave us a call, we mobilized. And much like Tom and the Walsh team, we had 6 of us available immediately with 3 more as an alternate team working off site. The first activity we did in the first 24 hours was we put the entire 1.3 million square feet of space in the 3 halls into BIM. These projects predated the use of BIM, and that allowed us to start to create control floor plans. And pictured on the left are 4 of our employees. Each three of them each were assigned to a hall, as was the Walsh team. So we had teams for Hall C, A, and B, and we worked very iteratively. And we created 2 main documents. We had the control plans, and then as Tom mentioned, one of my tasks was to maintain basically the scope of work through the PWS document. Slide. While this activity is going on in the actual work office, which was across the hall from the halls, we also had an ongoing construction effort occurring. We had teams of individuals under the management of Walsh and their own staff, combined with individuals from the National Guard, and we were busy constructing initially Hall C, getting those 500 beds activated. First order of business was to find all the floor boxes and to place the nurse stations so that we could readjust the pods. And we did that actually in real time, working iteratively as a team. We placed the pods, we confirmed utilities, and we began to develop diagrams and sketches. In addition to that, we began to do some inventing. We realized we were going to need ducted systems in at least one of the halls, so we began to test and develop ideas. Slide. These ideas included the use of modular design. One of the first and smartest decisions we did was we made all the support spaces 20 foot by 10 foot, 8 foot high, made out of 2-hour rated wall, so that we could make them gas facilities, gas storage. We could make them soil utility, and a satellite pharmacy. Pretty much any use that would be needed could fit within that module. And these were built, we had people modular building these literally 12 hours after the start of the project. We also leveraged modular construction, as you can see with the scaffolding for the ductwork. That also supported our medical gas systems, normal and electrical power as we distributed that. These separate pieces all came together and really resulted when we get, Tom will talk more on Hall B actually as an acute care facility. While the activities going on in the field, next slide please, we also were keeping track of decisions. As Tom mentioned, we had a variety of ownership interests here with the MPA, Army Corps, City of Chicago, and we had an awful lot of effort at coordinating and making sure that the efforts we were doing design-wise were matching up with those of the wraparound services. One of the values we, oh, go ahead, Tom.
Sorry, one of the key components there that Doug had mentioned was, you know, as the opportunity continued to evolve, every day seemed like a week, and we continued to get new players at the table. There's a couple that deserve a shout out because they're local Chicago folks that really were influential in this process. Dr. Nick Turkle and Martin Judd, both executives that have been in the Chicago area healthcare scene for quite some time, were instrumental in providing the leadership. And they came out actually a few days after we had started. So through the power of, you know, process and having these leadership meetings, Doug and I were able to keep track in a live cost event tracker what was happening, how it was happening, and the decisions that were being made, which made the process very, very fluid and very, very convenient to implement in the field.
Thank you, Tom. Next slide. And if that wasn't enough, we also maintain ongoing coordination meetings. And those of you who've worked with me know that this is a highlight for myself professionally. We had a great group of people that worked collegially and worked expansively. That very inventive crew of people that involved the Walsh project managers, trade contractors, engineering team from Thornton Tomasetti and environmental system design, our staff, the users. We had a evolving group effort to develop the inventive ideas. What was interesting was we were running 2 shifts. People need to recognize this was not a come in at 8 and leave at 5 exercise. This was a 24-hour operation. And in the middle of doing this work, we also had to do some rather large activities. Particularly, we had to develop a medical oxygen tank farm pretty much from scratch. And the great thing about this project was it was a mission. It was defined as a mission, and people had a clear goal. And I think one of the overriding features in this project is everybody was pointed in the same direction right from the beginning. Next.
So how do you do that in 25 days? You have to have access to top level leadership, and we had no absence of that. The picture on the left is Lieutenant General Todd Semonite from the Army Corps of Engineers. You might have seen him, you know, on the national news, standing next to the president and the vice president. He visited our site twice, providing us with leadership and guidance and resources. Mayor Lightfoot was there several times, was very interested in the process and helped us out immensely. Slide. We had Governor Pritzker give several press conferences there, slide, as well as U.S. Senator Tammy Duckworth. All of these individuals really did help us with that top-down management in order to make this a reality. So slide. Next, we wanted to talk about the facility itself and what was accomplished in those 25 days. Slide. And Doug, I'll let you give a brief overview here, but I'll start with the three different halls. So Hall C, Hall A, and Hall B, and I gave that order because that is the order that we did them in. 3,000 patient units in totality of varying different acuities. So Hall C was our first area, accomplished in 5 days, which was 500 patient beds, 14 nurses stations. Hall A was 1,750 patient beds and 41 nurse stations, and those were all in the subacute care. And then Hall B was made ready for 750 patient beds on the infrastructure side, but only 500 currently have been placed. And that is of our acute care area. And if you go to the next slide, Doug will explain a little bit more about those areas.
Yeah, this is really, as Tom has underscored, a lot about the numbers sort of paint the picture. We're dealing here with 1.35 million square feet of space, and this is space that previous to when we came there was nothing there, and when we left, there were 3,000 ability for 3,000 beds. In the three halls, you could see Hall C was 500 beds, which actually were 2 FEMA field hospital kits that were deployed. The major task in Hall C to start out was to quickly get the support spaces together. As I mentioned, the modular rooms, getting the hall set up into negative pressure. And I want to thank Craig Kos for his talk on negative pressure. We had to basically, we also had to provide bathroom facilities, and most importantly, we had to get nurse stations built. Following that, once that got complete, we deployed the team over to Hall A, and Hall A, as you'll see, is a much larger challenge. And then we'll end with Hall B, which is an acute care facility, as Tom had mentioned, which really deals with the true COVID patients. Slide. Hall C, as you can see, was, as I mentioned, was a pre-made COVID kit, or I mean, pre-made FEMA kit. We ring the perimeter with, you'll see colored squares with the support spaces that had to be created. And then we placed the gray nurse stations in the middle, which began to be placed for maximal observation of the patients. And remember, this all got built literally in 5 days. 5 days it was activated. And as you can see from the pictures, it was being outfitted. Next slide. Following Hall C, Hall A was a much bigger and different challenge. We broke Hall A into 4 quadrants. The quadrants, essentially, 3 of those had beds. The 4th one was reserved for future beds in the event it was needed. This facility had 1,750 beds within it. And again, each quadrant had its own collection of satellite pharmacy, med gas storage, environmental storage, showering facilities, et cetera, all mobile or modular. And so we did each one. We had a singular team here that was augmented with the team from Hall C. Next slide. And then you could see for Halls A and C, they had the open cubicle arrangement, which, by the way, we discovered that having people who have worked in exhibition halls and exhibition hall product line was extremely valuable for the ability to work quickly and accurately. Next slide.
So next we're going to talk about Hall B, which is our acute care area, or under the U.S. Army Corps' guidelines, a COVID level 2+. So these are patients that are not on ventilators, but actively suffering from the COVID virus. Each one of these yellow boxes on the graphic on the right is an individual negative pressure pod. So those were set up in series of 15 and they oppose each other. So each one of those areas of 30 pods was staffed by one team. On day one, when Doug and I started this process, we spent a little bit of time, not a lot because we didn't have it, looking at FTEs, full-time employees, looking at travel distances, looking at communications, and looking at adjacencies. And we found this to be the most efficient layout for all the stakeholders at the table. So what you're looking at is something that on a convention center floor has never been done before. We provided the infrastructure for these level 2+ patients, which is emergency power, medical grade head walls, inline oxygen, inline vacuum, and in the critical care area, inline medical air. So all of this, next slide, was done using modular and prefab, most of which was done off-site, trucked to the facility, and simply put together. The picture on the left here is our medical oxygen tank farm, which is located off the loading dock outside of the McCormick Place facility. And on the right is the infrastructure and scaffolding that we put together to accept all of the medium pressure duct, the copper pipe for the oxygen lines, and the vacuum, all of our emergency power. So really the bones that accepted all of the mechanical, electrical, and plumbing systems. Next slide.
It's important to note that the oxygen tank farm, by the way, weighed 334,000 pounds. It was on an elevated slab. So with the work of Thornton Tomasetti, we were able to structure that slab. And also the medical gas system was fully certified. What we have here depicted is placement of the nurse stations as the driver really for the placement of the modules. And then also we show the sinks, which were important because we placed these within proximity of the floor boxes, but not every floor box we discovered had water. So we had to make adjustments. And not only that, they did not have hot water. So we had to include localized heating for the water systems. Next slide. The patient rooms themselves, or spaces, should we say, for the acute care COVID patients were individual medical isolation pods. These were pods that the air would move through them and be drawn to the HEPA filter, which is pictured in the right, left-hand side of the picture on the left. This air would be then drawn through a HEPA filter machine and pulled up through the air systems that were ducted and out of the building. This facility created a negative air pressure HEPA filter environment. We also had modular head walls, which this particular cubicle is a critical care unit because it has medical air in addition to medical vacuum and oxygen. And we had 4 emergency outlets and 4 normal outlets for each of the critical care, or each of the pods in Hall C. Next slide.
So this is the orientation that I talked about previously with those 15 negative pressure pods ringing a central nurses station. Each one of those nurses stations had a Pyxis machine, electronic medical records, fully outfitted so that the staff, the doctors and nurses, the clinicians could appropriately care for the patients. Next slide. I mentioned there were a lot of people from the top down that were very interested and helpful in this job. 2 that definitely deserve a shout out here are Governor Pritzker and the Illinois Air National Guard, because it's not every day that your project gets its materials delivered by 2 C-130s at Midway Airport in the middle of the night. Those of you that are local to Chicago might have seen this on the news. It's the first construction job that I've had that had 3 news helicopters live videoing our operations, but it was certainly appreciated and part of the reason that we were able to be successful within the 25 days. Slide. And here you have a picture of those pods. Doug described this pretty well here, but we just wanted to give one more look. On the left is that negative pressure unit, the HEPA unit. Right, custom-made head wall. We brought in medical exam lights, and then the kits for the beds. Each one of the tents had its own nurse call system on it as well, and the nurse call was able to be monitored by both remotely as well as on-site. Slide. So we wanted to go through some finished photography here, and I'll let Doug show you a couple of these. Slide.
Sure. Just as sort of a photo conclusion, we have Houseal, which many people have seen this photo. This is the one that got a lot of news time. Again, it's an open cubicle type assembly. And you can appreciate the immensity of the effort to get this done in 5 days. Next slide. And Hall A under construction, as you can multiply this by about 4 to get the sense of the immensity of this challenge. Again, we had 1,750 of these pods in or cubicles in our facility. Next slide. And then Hall B, as Tom underscored, you can see the immensity of the effort to create the infrastructure and to house the pods. This was a fantastic inventiveness. I think that's the thing I would term it as, is there's an inventiveness here, which was a team effort. It certainly went across, people worked across boundaries and traditional practices. So that led to the great success on the project. And last slide. And we leveraged to the hill these capabilities of the scaffolding systems and being able to cart these systems. Next. And this is a little bit of a before and after. You can see the size of the hall, and then as you start to fill it up with the various attributes. And obviously, as we keep talking about, this was definitely a mission. And this was a group of people achieving a common mission to meet our goal. Next.
So I'm going to start with the lessons learned, and you can go to the next slide, please. You know, we're going to start with safety. For 25 days, we worked 24/7, thousands of man hours, and we went with 0 incidents, not even a first aid. And more importantly, in our COVID policies, absolutely worked. There was not one single incident of COVID across thousands of man hours. The next thing here is team and speed. Unless we were not wearing our individual hard hats, no one would have known who was working for the U.S. Army Corps of Engineers or Stantec or ESD or Thornton Tomasetti or MPEA. We were all one big cohesive team. And I know everybody on this video has been a part of teams and co-located, but super proud of people that kind of put fear aside, laced up their boots, put on their hard hat, and just went to work. This job was absolutely modeled on civic pride. We were all doing something for our city, and something we're all very proud of.
I think, Tom, I just want to underscore before we close the collegiality that was present here, and I think the leadership of that extended through the owner to yourselves at Walsh is to be noted. And I think there was obviously a project of a lifetime opportunity. So thank you.
And I think one more slide. And so a thank you to everybody that listened, and a thank you to the team. This is just a small snapshot of the folks who were there, but on the right you see us with the certificate of occupancy. transferring the space back over to the MPEA and the Corps of Engineers. So with that, thank you for your time.
Thanks so much, Tom and Doug. We really appreciate you guys taking the time to present this for us. So to all of our attendees, as you know, we did extend the length of this event to run until 1:30, and we want to be cognizant of your time. We extended the event so that we could get more details, especially on our case studies. And now we are going to be entering into the Q&A portion of our webinar. So just a couple of quick reminders. With the Q&A about to begin, you still have a couple of moments to, apologies here. I'm having some connectivity issues on my end. Sorry about that. So with the Q&A about to begin, I will just remind you guys quickly that you can still submit questions using the Q&A button that you guys have at the bottom of your screen. After the Q&A ends, immediately after the program, you are going to be greeted with a survey that will enable you to register your CEUs and sign up to learn more about CTBUH and CTBUH Chicago. We certainly hope that you'll sign up to receive our correspondence and that we'll see you at some of our future events. And then as another reminder, the program follow-up will be to your registration email where we send you relevant links, and we'll be responding to any of the questions that we don't get to today. So we have had a handful of questions coming in. And actually, I would like to start off the questions with the McCormick Alternate Care Facility team. So if we could get their mics unmuted while I look through this question quickly. So with regard to the work that you guys were doing down at McCormick Place, you guys have already mentioned that it took a lot of coordination amongst your teams and a really good understanding of teamwork to get things done. Can you speak to any of the best practices that you guys used in communicating across your teams and the multidisciplinary groups that you had in place while you were trying to address this rapid speed project?
Tom, you want to start first, or?
Go ahead, Doug, sorry.
Okay. As far as best practices, obviously, we had the benefit of face-to-face meetings, our ability to communicate more directly. That, particularly in the urgency of that, being able to, A, get the project into some sort of usable format, BIM, and second, being able to organize ourselves into individual hall-based teams that became like SWAT teams were two practices that I think elevated the amount of communication that occurred on the project and empowered individuals to make inventive decisions.
Hey, Doug, I was garbled there. I missed the question. Was there something for me?
They asked about some of the best practices that we employed. And I know that your team, on the construction side, we employed many best practices.
Yeah, I would say that, I mean, probably 10 we could talk through, but the biggest was standardization. We came up with a standard module and then applied that across the couple thousand lower acuity beds. And then for the higher acuity beds, the same thing. Once we had a standard, once we knew, how many nurses we would need per space, how many doctors we would need, once we figured out the adjacencies, very quickly, we were able to come up with something that could be either scaled up or scaled down very quickly.
I think it's interesting that you touched on the modularization as a response to the speed at which you had to get things constructed. And Doug, I remember during our preparation for the event, you had mentioned that you guys had to look at some unique resources to bring construction materials into the project, one of which was the exhibit booth designs that you touched base on. Could you share with us any thoughts on how you think other, how there might be more collaboration with these types of unique type of sources in the future, so that the AEC industry can learn to better respond to public health crisis or any other sorts of crises that might necessitate a rapid construction of projects and access to significant amounts of material?
Okay, absolutely. Just very quickly, one thought is, now that we have a large group of individuals across the country who are aware of these types of products and these types of methods, being able to now catalog these and maintain an inventory across the country would be certainly very useful. And also having healthcare facilities or others be the curators of these, you know, within a designated community would expand the ability to respond in the future. It's my hope that this will be more of a coordinated effort across the entire country. And I know several national organizations who have already begun to champion the development of national standards for pandemic response.
Doug, I'll take that a step further as it relates to the state of Illinois, and specifically in Hall B, which was our high acuity area or the isolation area. Part of our task was really to figure out how this could be used in the future. So all of these resources, you know, in the 15 pod unit could be boxed up and shipped, you know, somewhere within the state in the future. So we didn't want to lose sight of that. We didn't want to create a, you know, we wanted to have a resource that could be moved on. And that was part of the planning and design process from the beginning, which is nice to know that the resource is there moving forward.
Thank you for that feedback. We've had a couple of questions that also came in for the Rush team. So I'm going to switch the mics over to that. Doug and Tom, you guys are going to be going on to mute here. And we'll get Jerry and Craig online. And I would like to ask you guys, and in particular, this is directed at Jerry, but I'd like both of you to provide insight. How do you see the success of Rush University Medical Center's pandemic ready design altering future healthcare architecture best practices? And do you think it's important for all major hospitals to have surge capacity post COVID-19? It'd be great to hear your guys' thoughts on that.
Yeah, thank you, Shelley. I guess thinking about the current pandemic and how Rush responded, there's two thoughts that come to my mind. One is the thoughtfulness of the planning and the design with respect to anticipating the current events, and also being able to respond as efficiently and as quickly, both with the infrastructure and with the space requirements that are needed. The second way that I think could inform future projects, that is a strong lesson learned from Rush, is the way in which the medical center organized themselves during the design process. They did a very wise thing in that they organized this Office of Transformation led by a full-time hospital administrator. And he surrounded himself with very dedicated and smart doctors and nurses who sat with us and collaborated with us on a daily basis and were imagining things that back then did not seem that could occur, which is happening right now. That process is just as important as the actual planning. That OOT team was not only assembled with very smart and capable people, but they were empowered to make decisions and report directly to the CEO and the COO of the medical center. And I think that is a great lesson too of Rush.
And to Craig, did you have anything that you'd like to add for that?
I think definitely from a mechanical standpoint, when we start to develop the plans for a hospital, we'll definitely need to engage in conversations about what you do to respond to a pandemic event or an event where you need to increase your capacity of isolation of patients. Certainly what Rush was able to do with their emergency department and creating whole wings within a hospital that can respond to that need is, I think it's going to be an important design aspect for engineers and owners to be looking at. I think coming out of this, we may even be talking to different hospitals about what they can do to their existing systems to prepare for an event in the future.
Wonderful. Well, thank you guys. And I do want to close out our Q&A now because it looks like we're coming right up to the end of our presentation. I'd like to take a moment here to just say thank you. Once I can advance my slide. I'd like to extend a very big thank you on behalf of CTBUH Chicago to all of our speakers, to all of our attendees, to all of the essential workers who are out there helping us fight this disease. And again, I'd just like to say thank you and stay safe, everyone out there. Again, if you guys enjoyed what you saw here, we would certainly love to see you at our next event, whether it be virtual or in person, although it's sounding like the next one will be virtual. So feel free to reach out to us at chicago@ctbuh.org or on our LinkedIn page where we're available under CTBUH Chicago. And if you have any questions that are outside of the Chicagoland area, you can learn more about CTBUH at www.ctbuh.org. Thank you again for your time today. All of the rest of the questions that came in through the Q&A, we will be presenting those back to our panelists. And if they can still afford us some time, we will send out the responses to those when we send out all of our closeout documentation. Thank you guys for enduring our first virtual event for CTBUH Chicago, and I hope you all have a safe and wonderful rest of your day. Bye-bye.